There you go. Thank you to everyone that showed up right now, and for everyone in the FMIG members that are going to watch this later. We're really happy to have Dr. Adi Schoeman with us, and she's just going to take us through a talk today for rural medicine. And she's very experienced in what she does because she has a lot of experience with rural areas. And she currently is practicing in mainly rural South Africa, and then also goes sometimes in a small town in Canada. She'll obviously tell you more about this. So you can take it away.
Oh, thank you. Thank you, everybody. And thank you for the invitation. I really enjoy this. So yes, I am a doctor here in the small town of Patensi in the very tip of Africa. And I'm going to give you a little bit of background so that you can understand how we do medical practice in South Africa. Okay, the next slide. Thanks, Mix. Okay, is it showing on your side? Megan? Megan?
Yes, can you not see it?
No, I can't see it. But can I assume? Yes, there we go. I can see it now. Good,
Okay.
great. Okay. So I'm starting out to say to the world, I'm just someone, but to someone I might be just the world today. And I really would like you guys to keep that in mind. That's my motto in my life. That's my motto every day, to say, you know what? I'm just someone. You guys are just someone. But to someone, you might be the world today. So keep that in your back of your mind every day when you do practice, because that comes up almost every day in your daily normal practice. Okay, the next one. So that's why I'm saying you are that someone. You are the one who has to make the difference. You are to lead and inspire and live by daily example. Show your heart and shine your light. Next one. So who am I? Yes, I am Dr. Adi Schoeman, and I'm married to a Ferrara, and we live in Patensi. I've been in general practice for 30 years. And then in this little small town that I live, we farm with citrus. So I have a husband, 2 children, and 4 dogs. There is the husband, the children, and some of the dogs. So Patensi, I need to give you the background here so that you can understand. It's situated in the Eastern Cape. And from where I live and where I work every day, my nearest hospital is 100 kilometers away. So if you're in a small community, 100 kilometers away for any ER, any ICU, any high care, or any hospital bed, you've got some challenges. So this area is vast, and we are having approximately 32,000 people in high peak season in our area. If I say peak season, it's usually when we are picking these oranges, picking and packing, and this is starting March till September. Therefore, I am the emergency room in my immediate facility. I am the cardiologist, the pediatrician, the gynecologist, the oncologist. I am the physician, and many more. And that is actually the challenges of living in a small community far away from bigger centrum. Thanks. Okay, so that's just so that you can see we are at the very tip of Africa. That's where we live. That's the name of the town. It's called Patensi. And you can see that we are quite remote away from big centrum. This is my office in town. Can you see? This is my office. Okay, so now you've seen the office in town. My next one is what happens after hours. Because there's no emergency room in my vicinity, in my area. I am the ER, and everybody after hours and over weekends when they're sick or when they have there's a car accident like this morning, or a heart attack or a fracture, they come to my house. And at my house, I have two offices, a bigger office and as well as a procedure room. And that's just so that my husband is around, that I don't have to go to town all by myself, and that I do have a bit of help over weekends. My family, which is my husband and my children, sometimes has to help me when there's a big emergency, and they are once or every second year we do a BLS with them or for them, so that they are able to help me. So this is you can show me my after hours. My house on the farm, because there is no ER available in town. Or I am the ER. Okay, so you will see that I do like to attend to detail, and I do like to have modern equipment in all my offices. So yes, just a little bit background here. I live very close into my community. I live with people. I know the financial background of most of these people, and I know who can afford the doctor and who can't. So I ask $20 approximately for a consultation, and that will include the medicine. I have the ability to go and ask the privileged people or more privileged people to help me, and pay for less privileged people, especially if it comes to special investigations like blood tests and x-rays. In my town, I don't have any blood availability immediately to blood tests or any x-rays. That has to be done in the city, and we have to arrange to get the patients there. So that's also part of the challenge. And therefore, I do have an ultrasound, which I really depends on lots. It's like my second stethoscope. And if you keep this in mind, that I really have to depend on my skills as a physician, and all my senses is involved to make a good diagnosis to my patients. I always ask, why is the patient sitting in front of me? Because some of these patients is traveling quite a bit of distance to get to me. And I always need to tell you that never assume, if your patient is sitting in front of you saying, I'm coming from a doctor or I'm coming from the nurse, and they say, I have blood pressure, I have diabetes, or I am pregnant, never assume. Double check for yourself, never be rude to your patient, always stop, think and ask why. Whole time, why is the patient here? Why does it take so long? Why, how many weeks, how many days is this patient presenting with these symptoms to get to a very good diagnosis? It's all actually in front of you. If you allow the patient to really tell you the history, you will be able to put it together with, I don't have access to x-rays and blood tests every day. So you have to think, stop, think and ask, okay? Okay, now last week, this is just giving you an idea of what's happening in the practice. Everybody think a GP is seeing flus and colds. We don't. Last week, I've seen 223 patients. And out of that, that was very interesting. We had a 1-month-old baby that we had with a total resus. He came into my office in septicemia, and I was able to rush him to ICU. I had an 8-year-old that had mumps. You know, it starts off viral infection, not too bad, but then he showed, mom phoned me not doing well. I said, come back into the office, put him on IV, and then he for sure had an encephalitis. Important not to miss that, and make sure that I don't keep him with me, that I do send him off to be seen. I don't send everything off, because remember, a good GP should actually be able to handle and care for 95% of all these patients. So there is a bit of percentage of patients that you have to be clever enough to get soon enough to your bigger facility. I had a 55-year-old patient that presented with epigastric pain, assuming that she had a peptic ulcer for the last 2 or 3 months. It's been building up, not doing well. Ultrasound showed that in my office showed that she had a pancreatic tumor. So never assume. Check, check, check. And then I had a 38-year-old male patient coming in, also assuming he had heat stroke. He was out, it was pretty hot that day. I saw him at about 6 or 7 o'clock at night. It was very hot outside. He was diaphoretic and he was in shock, but he came in with the wife assuming that he had heat stroke. He didn't. He had a unstable atrial fibrillation, and there was no time to wait to get him to ICU immediately. I had to give him 100 joules of synchronized electric shock, and then I was able to move him into ICU for the night for observations and get him to the cardiologist, etc., etc. So that's interesting that keep in mind that a general practice doesn't see flu and colds. Yes, we do, but you have to be wide awake to make sure you get all your other diagnoses. So this is my daughter. At this picture was taken, we said 4 years ago, it was 3 years ago, the beginning of COVID in January, no, it was in March or April of 2020. She had to, one Sunday night, she had to help me to deliver this baby. It was a Sunday afternoon about 4 o'clock. A youngster walked in, I think she was about 21. No, sorry, she wasn't. She was 19, yes. She was 19, she walked in stating that she has a urinary tract infection, and the mom and dad was with her, had fever, abdominal pain, don't feel too well. On a good examination, she was 39 weeks pregnant and in full labor. Now, the mom and dad was so shocked that I had to rush and get my 16-year-old to come and help me so that we were able to deliver the baby, which we did. And then the grandma said, I'm not taking this baby home, not the mother or the baby home. And I turned around and I said, listen to me, I'll tell you what, you take the mother and the baby, because this baby needs the mother. She's going to breastfeed this baby. And then 1 year later, you bring this baby back to me, and then I'll take the baby and I'll raise the baby. But what's going to happen is you're going to tell me 1 year later, doctor, what a joy and what a blessing. Now, what happened is that mom was in grade 12 and she wasn't able to complete her high school. But I got this picture. I'm going to show it to you right now. The baby is now 3 years. Mom was able to graduate. And the grandma sent me a note with this picture stating, what a joy, what a blessing. So a pregnancy, and a pregnancy is not the end of the world, guys. You just have to help people to realize that in time, this is going to be a blessing and this is going to be a joy. So, I mean, being pregnant is fine. A cancer diagnosis is way worse. That's why I'm trying to teach my patients. Okay, the next one. Okay, so this youngster was found and brought in by social services and police. They found her under a bush. The mom rejected her. And if you can open up a little bigger on the sides, this was impetigo that she had secondary to NSIC bites in her face. And I think it's because she probably fell asleep, didn't realize. And then over a 3 weeks period, we were able to get her nicely cleared up and much better. So yeah, there's quite a bit of social problems as well that you have to think of and that you have to assist, right? This was a farm attack. So one of the farmers was attacked by a machete. So they brought this guy in about 2 o'clock in the morning, full farm attack, him and the wife. We were able to help both of them. Okay. Okay, stop here. Stop. This guy, I have to tell you the story. So this guy was sent to my, he got a nose polyp for about 3 by 5 centimeters, huge polyp. And I was able to get him in to see the ear, nose, and throat specialist who took out the polyp. And then this fellow lapsed, didn't come back for the follow-up. And 6 months later, he showed up my office and he's telling me that he has difficult breathing, but the breathing wasn't a problem. He had a very, very offensive smell, like very offensive. Nobody want to work with him or work with him, next to him or whatever. And this is what happened. I was able to pull out, and you have a look at 2.5 meters of gauze that wasn't removed because he didn't go back for his follow-up. So interesting, right? There you go. Yep. And I'm standing in my COVID suit there. So it was about middle May, March 2020, April. So good. The next one, let's just see what I've got. Okay, stop there. Can you stop? Yes, thanks. So this fellow came in, he was jogging, and you know how these are jogging and then they jump over a pole, you know what, standing somewhere and they just fly over the pole. So while he was flying over the pole hit him on the left inner thigh. And then he developed a huge hematoma. And he was seen by a couple of doctors in State Hospital because he was complaining about severe thigh pain. They at that stage was thinking it's his hip, so they did a couple of x-rays, but nobody did a full blood count on him, because then they would be able to see that he was probably having, you know, elevated white blood count, because he had a huge abscess that we then drained in my office. Okay, Max, you can start that one now. And we drained 1.5 liters of pus there. Okay, this one, and I'm putting this in to tell you and show you, I'm not judging, I'm showing you. This youngster had a cesarean section done by an inexperienced team of docs. So the cautery plaster was put onto a gluteus, and it was supposed to go onto a left or right upper thigh. So when they started operating, the body fluids was running down, and she was lying in her own body fluids, and then she got a 3rd-degree burn wound from that quartering plaster that was applied. So you know, it was terrible because I had to explain. She couldn't understand. The cesarean section incision wasn't the pain, wasn't the problem. This was a huge problem. She had a newborn baby that she had to take care of, but she could hardly walk. And I know she was sitting in front of me and she said, I don't understand how this happened. So it was difficult to get her understanding that this did happen, but eventually we were able to help her. But keep that in mind if you're taking care of your patients. I know we learn never to do harm, but sometimes stuff happens. And if it happens, you need to take the patient and explain to the patient so that they understand. And once she understands what have happened, she was able to deal with this, and we were able to get her well and okay. She actually healed very well because she was so young. Okay, so during the pandemic times, we have seen many sick patients. We have tested 10,249 patients positive during that time. But with the local farmers, we were able to put up a COVID isolation unit in town that was away from my office. We were able to put in 26 beds with oxygen and medication. And this was all paid for from the local farming community, and patients was able to get very good care, and they didn't pay for anything. It cost them nothing. And we were able to help them instead of sending them away from the town, from out of town, into a bigger center, because everybody was scared at that stage, and they were afraid that they couldn't find their people, or what would happen to their people if they die, etc., etc. So it was challenging times, but I was able, with the community's help, to really put up a good functional unit. Yeah. Okay. So this is the unit. It was an old building. We painted it red, and we were able to put beds into it. It wasn't fancy, but it was something. This is my team. You can probably just know that if you are in town of my size, there's a full team of 10 ladies that is helping me. And this is, this is girls that's working for me in the office. The physiotherapist comes once a week. The occupational speech girl comes the speech therapist comes once a week. Occupational health comes once a week. Optometrist comes once a week, but this crew is with me every day, and I cannot do it without them. Yeah, that's the crew. And so I end up to say to the world, you and I are just individuals, but to some individual, we might just be the world today.
Well, thank you so much, Adi.
Thank you for the opportunity, Megan.
Yeah, that was really amazing. And all the different cases you went through, I think were a lot, at least for me, I can say, were very surprising that you see such a vast variety of cases as a family medicine physician. I think here the standard is very oh, you're just going to be in a clinic from 9 to 5 and you're not going to see diabetes patients, but that was very, very cool to see. I don't know if any of our members have anything else to add before we get into questions, or okay. Okay, so we'll go through some of the submissions of the questions. Someone asked, I know you kind of touched on it. It says, does your practice include obstetrics care and or abortion care? Why or why? Okay.
Okay, so what we do is, because I have the ultrasound, I get, it's pregnant, I'm doing the pregnancy scans, but because of insurance purposes, I have given up I don't do any labor anymore. It's just for insurance reasons. There's just too much involved. You guys know that. So I make the diagnosis. I make sure that it's an intrauterine pregnancy, and we make sure that the placenta is fine. We follow the baby's growth, but I'm at the stage then we'll send to the OBG, and it's usually about between 12 and 16 weeks. I send to say, okay, this is all that I've done. Now it is for your further management. And I do see them, because remember now it's 100 kilometers to drive. So I usually say, okay, you see the OBG for every second month, and the month in between you see me. And in that way, I'm still involved in the pregnancy. But if there's any problems, I am able to send it to the OBG.
Awesome. And then following that, they said they wanted to know more about if your practice or even the OBGYN practice in the rural town provides abortion care, and what are your thoughts?
No, they don't. The clinic don't. I will prep them. I will inform them. I will tell them Let's have a look at all the options. I will do and make sure that they have an ultrasound. I tell them that anything between 12 weeks, it's fine to do. After 12 weeks, it gets difficult because then it's another clinic. So if it's up to 12 weeks, I know where to refer them. But after 12 weeks, it's a little bit more tricky on this side. There is somebody that's doing it, but I talk to them, I guide them, so they make the right decision, and then we send them off to according to the weeks where they will get the right help.
Okay. And then this next one is a little bit more general. So they asked, what is the greatest challenge affecting rural medicine accessibility? Even when you were like starting up too, right? I'm sure that you had to face many like challenges before creating all these clinics.
I think money. I think money is like, if I have money without asking, like some people just can't afford and some can, right? So obviously for those that can, you can do the blood test, the full blood count, the chest x-ray, everything. But a guy walking in that I can only afford $20. You really have to think how you're going to manage that, make the diagnosis, and give him right medication for $20. So the whole time, I mean, I've got patients in my town that will pay $200 or $300. They have no issue. They can do that. But so it's all about giving and taking. And at this stage, I mean, if I think somebody's very sick and they can't afford it, I usually phone the employer. I usually phone somebody that kind of whispered in my ear before to say, I would like to help someone if it's need be. And I'm talking about like an MRI. MRI in my country is about $1,000. So if an MRI needs to be done and you can't afford it, and that's to make sure, or that's to definitely make sure about the staging of a cancer with notes, whatever, then I usually phone somebody that is saying, okay, you know what, I will sponsor that person. And in a way, we get it done. And by just getting the right diagnosis, then again, if I can put the patient up with the right diagnosis, it's easy to get him into the state system. Now, you have to understand there's a private system and there's a state system. So if you can't afford it, you can go through to the state system, but I found that the wait periods is extremely long. So I'm in between. I do private, but I do a little bit of state, and I actually jiggle and jive to keep them all together to know where to send them off, and that does help.
And then the next question is, someone said, because I know you ran like an all women's clinic, and I'm sure you're right. So yeah,
they didn't tell you about that. So I can just tell them, because you're probably going to think, how do I get this all done? So I have found in general practice that if a patient, there's nothing wrong with the patient, you just want to do preventative medicine, you don't have time, right? So I have started a all-female practice in Port Elizabeth, which is 100 kilometers away. And there's 8 of us doing that. So you come in for a good, complete physical. It takes about an hour, which I don't have in the rural practice, okay? So I go there every Wednesday. So every Wednesday, my practice in the rural, because I live in the rural, on the farm, I'm there every day, 24/7, night and day. But Wednesdays, I'm not in town, and everybody knows that. So I have a nurse in my practice, and if Megan is here visiting me and she's the student, she's in my practice, or I had a couple of students here, I leave them here all by themselves with the nurse. Everybody knows Wednesdays I'm in the city, and that's when I do my female health practice. And that's very more first world, and very more, and that's good, because that academically keeps me up as well. So and then if it's 6 weeks in a year, I try to go to Canada. I've been there in a specific practice that I practice medicine, and I love being there, because then I don't do my after hours is not as much. So that's nice. I always say it's my vacation, my medicine vacation, because I know everybody in town, we chat at the co-op, but yet I work, but not as hard as here. So that's actually my vacation. And that's also just to keep and maintain first world practice, and come home with good ideas and good planning, you know. So then and that's all by, doing that, I can give it back to my community. I can get that knowledge back into my community. So that's how I plan my time, just so that you know that. Now, you want to ask me something about the Women for Life practice?
Yes, I just want to say that's a very smart setup of like taking your time and dedicating it to like first world clinics too sometimes, and then like bringing it back, which is very interesting. I've never really seen that before. Before we get into that, because you talked about the Canadian practice, I did want to ask, did you notice any like differences in terms of like the patients you're seeing or what are the top differences between like the Canadian patients and like the South African ones? Yeah.
The Canadian patients is more informed. They are more, it's easier to connect with them and explaining to them their disease and their medication. In South Africa, only I would say 30% of my patients really have insight if we start explaining to them the medication and what the comorbidities on their diseases. While the other 70% is really difficult sometimes to say, listen, you have to take your blood pressure medication because this and this and this can happen. That's the one problem that we have. On the other hand is the local state clinics doesn't always have their medication. So if a patient is sitting in front of you and said, I'm out of medication, it's like, why don't you take your medication? It's not that I don't take my medication, doctor. It's the state clinic doesn't have medication to give to me. You know, so then I said, okay, let's see what we've got and how we can do this, because the chronic medication of patients can get expensive, you know, and for them to pay out of pocket, sometimes it's just not possible. And that's why we do rely on the state. But I mean, at the moment, they are out 6 weeks on ARVs in my area. So we see quite a bit of HIV and TB, and that's medication that needs to be taken daily. And if the local clinic is out, the state clinic is out of that, I mean, then, you know, it is not good for the patients.
Yeah, we see a little bit of that here in Grenada when we're, for the term 5s at least, when we're doing like our hospital simulation or hospital rotations. Like recently I had a sickle cell anemia patient, and she looks healthy and everything, but literally just the pharmacy had run out of hydroxyurea for the last like month or 2 months. And yeah, it affects them like so quickly. And it's unfortunate because it's not really something in our capacity to change, you know.
But you know, that can eventually help her, you know, I mean, you'll be able to do that, if you know what I mean. Like, yeah, you know, there's somebody that then you, and that's why if you live closer to the community, eventually you will know, well, this guy, I can ask to help that guy, you know. So, okay, sorry, I'm interrupting.
Someone asked, how should the modern male physician ensure that they're appropriately being an advocate for women's rights?
Oh, well, that's a very good question. I think being gentle with your patients, honest, always honest, and I believe that you live by example. So if you are the same every day, taking care of your patients in a way that they can see it, you don't have to talk. You don't have to see. They see. If you are, I said, we're walking a road. It can get bumpy, and you can get tired, and you can get frustrated. But being consistently every day, step by step, you live by example, and they will attach to that. Doesn't matter if you're male or female. Yep.
That's a good answer. Someone asked, what do you see as the greatest transition ahead for family medicine? Do you think the field is slowly being phased out by ARNPs? Or I don't know if you have like a sort of similar in South Africa.
You know what's my biggest concern? Mm-hmm. That the younger doctors think you can do a telecommunication Zoom meet consultation with your patients. That's my biggest concern, because people need touch. You as a doctor will never get experience if you don't see, feel, smell. And everybody wants to do this thing on, okay, like that, they're even asking me, doctor, can we book a telecommunication because I'm sitting in wherever? let's say I'm sitting in Port Elizabeth and I want to communicate with you, can we do a consultation? I'm like, no, I don't do it that way. I want to see, because patients, their friends, their tea parties, whatever, make diagnoses, and you need to see for yourself and touch and prescribe and guide. And my biggest concern is that the young, everybody young, not only the doctors, but also the patients, wants to have this very easy way that's suiting everybody. And that's my biggest concern for the future, because we are going to miss the ball 6 love, honestly. And the other thing is, I know they're bringing in this artificial intelligence to guide us and to help us, etc. But there's nothing that gets to a experienced GP. I mean, nothing. You actually, that month-old baby, they walked in by the door, and I'm like, I was standing in front in the pharmacy. I lift up my head and I watched the baby. I'm like, get the ambulance immediately, get back in your car. I'm sending a nurse with you. And the mom is like, I want to get a toothbrush. I said, you didn't stop nowhere. You got no toothbrush. I am ordering a paramedic from Port Elizabeth who's going to meet you halfway. That child has said to see me. I will not see tonight. And you cannot see that over Zoom. So I think really that's my biggest concern. We're going to be doing this, that's just what I think or worry about.
Yeah, that's fair. The telehealth, even like I'm from Canada, and we do have like some sort of like telehealth portion. But it's interesting because you go and like say what your symptoms are, but then they say we can't, if you have like a hurt wrist, for example, you can't show them that because it holds them liable. And it's really weird. Exactly. And then they're like, okay, actually go to the GP. And it's like, just avoid all those steps.
Another thing is, I think if you have good, educated, well-trained GPs, 90% of all problems can be solved in your GP practice. And you're not like, everybody, like you can see the specialists are booked. They're fully booked for the next 3 months. They're fully booked. Why? How? Because everybody, I have my pediatrician. I have my gynecologist. I have, like, really, your GP can do that. And if there's a problem, the GP will refer. So everything should go through the GP. That's making the GP have to be on the ball, okay? But that's why I said we don't have to overbook our specialists like that and wait 3 or 4 or 5 months for somebody that really needs to see that doctor.
Right. I see Celine, you have your hand raised. Do you have a question you want to ask?
I do. I actually have 2 questions.
Yes.
So first of all, thank you so much for such a wonderful presentation. I think we all learned so much. My first question, so I did notice in your presentation that just last week you mentioned you had 223 patients. That's a really big number for such an intimate staff crew, right? Because you guys are only 10. Do you feel like you can assure your patients you're going to be available to them, considering how busy you are?
Celine, that's the problem. Being 25 years in a community like that, sometimes I start 6 o'clock in the morning. Sometimes I'll go till 10, 11 o'clock at night to see that amount of my patients. And I really, really pray every day, say, please, God, let me be good to everybody sitting in front of me. But the thing is, if you live in a community like this, there's certain people that's standing in front of you and like, I haven't seen this guy in a year. What's wrong? There must be something serious wrong. Let me just sit still and check this out. You know what I mean?
Right.
So it is kind of a sixth sense that I also have in a way after so many years in a community like this. You just know. And I think I think really God protects me because he kind of lead the way. I just have to listen what he's showing me. But yes, it is difficult.
Mm-hmm.
And people have to wait sometimes. I mean, they have, and I'm not talking wait, is they have to wait an hour or an hour and a half to see me, and they're sitting to wait me. And I'm like, they're waiting to see me. I'm so sorry, they're waiting so long, but I have an emergency. That's fine for them. They know. So yes, it's not the ideal. I mean, I think we saw 72 last Monday. That's too much. But
Right.
we saw 72, and we handle them in a way. At a stage, I think I'm going to get tired, but at the moment, I'm going, So yeah, we do handle them.
Okay, thank you so much. And my other question that I was curious about is, So we do talk a lot about, medical strengths and everything that you do with the clinic, but I was just curious what you feel is your greatest like non-medical strength that you bring to your practice.
Oh, the way I dress. I love nice clothes. And shoes. And I bring that to my office every day, hopefully to inspire a young lady somewhere along the line.
That's fair. Okay. Thank you so much.
Okay.
We have another question, and it goes, do you have any advice or tips on how to narrow down so many diagnoses into like the pertinent ones when you have such a limited medical technology to help you with your diagnoses?
Okay. I have a nurse that has done, she's an obstetric nurse, and she is very good at what she's doing. So she is working hand in hand with me, and I really trust her sense. If she's picking something up, and this is one thing that you guys should know very early. I am as good as a doctor because of the nurses I have around me. Acknowledge your nurses. I constantly say, yes, great job, well done, you got this. Because if something she is doing her job 110% because I rely on her. I see the patient, but 110% is what she says to me. So and she's really good at what she's doing. So they first usually see her and she's like, oh, can you come and have a look? I think this and this might be a problem. And then it's easy to say, okay, yes, you're right. Her blood pressure is elevated, and usually by the time I was saying the blood pressure is elevated, she's already getting ready to do a urine sample and a blood test for the HELP syndrome. So there's and this is all about a machine that is mechanically working well. The one hand's going into the other. So I have a pharmacist on site. I've got 3 nurses. The one is doing lots of obstetric, one is doing primary care, and one is doing all the interaction between patient and what we like. Your blood pressure, your chronic medication has run out. You need to come in. We need to do a full blood count. We need to check a hemoglobin 1AC. We need to do lipogram because can we make arrangements for next week? So I've got one nurse that's taking care of that. She also phoned them with results, etc. And then one girl primary care and one girl doing obstetrics. So yes, I kind of try to get there. And then I've got an older nurse that I send out to the farms, to on site. And so she's got a little roster that she's doing, and she visits the farm. So that's also helping to get patients good medical care without coming to the doctor, So, and if she picks something up the next day, she'll say, okay, I need you to see the doctor. So you have to go into town and see the doctor who some of these oaks don't have appointments. They just walk in. That's the other problem, but we sort them out. Yes. Because if you see 72 patients a day, half of them only has appointments. The rest is just rocking up, coming through the emerge. That's the thing that you have to keep in mind.
Wow. And then we have a question of, if you could tell your younger self anything about the journey, what would you say?
I didn't get that. Did you ask me if I have to ask my younger self?
Yeah, if you could tell anything to your younger self, anything about your journey. What would you say?
Don't marry the farmer in Patensie because you're going to be responsible for the whole community. No, I think, yeah, well, that's one to me. I love what I'm doing. It's a passion. I love my job. Perhaps, and I was thinking perhaps I should have went and specialized, but I think it's quite boring to see everything or the same thing every day. And that I know now that I can't do the same thing every day. Like my women's clinic in Port Elizabeth, where I go once a week, that's enough for me once a week, because if I have to do all of that every day, it will get bored. Here it's exciting. You don't know what's walking through the door. You don't know if there's a tractor accident, if there's a hunting accident, if there's a baby with a septicemia. You don't know. It's every day working up, saying, dear Lord, give me the strength today to be the best physician to everybody sitting in front of me and not losing one. That's it, every day.
Wow. And that kind of goes along with our next question, where someone's asking, why do you think primary care is not seen as such a high priority profession? Like, how can we educate others about why family medicine is important and necessary.
I want to say everything is primary care because you pick up so many things in primary care. It is actually amazing. But secondly, it is us, or it is, I think it's the people and the world telling everybody, like, you have to have a gynae, you have to have a psychiatrist, you have to have a pediatrician, you have to. That's not the case. If you have a good family physician, family doctor that knows what he or she is doing, you are actually in better hands. I have many times in the last 6 months had to pick up a phone the hospital and fight for my patient that's lying. And this is one case that's coming up. I had to phone and say, listen, this patient is 52 years of age with a list of comorbidities. She's a diabetic patient. She cannot be in a normal ward. She needs to be in ICU. And it was left and right and up and down. Eventually, I found the hospital manager. I said, look here, if you don't put my patient in an ICU ward or bed within the next 24 hours, I am going to be in your office knocking on your door tomorrow morning. So sometime, and I'm just a GP, 100 kilometers away. Well, she was 77 days in ICU at the end of the day. They missed her ruptured, she had a ruptured colon, and they missed that. And all I was responding on was the info I got from the family that was sitting in my office that didn't want to go away. Said, look, you have to help us. She's going to die. And this and this and this. And eventually I got involved. But I mean, is it the job of a family physician 100 kilometers away to tell them to move a patient to ICU? No, it's not. But it actually is. It happened. It happens, you know. So a good family physician in primary care will pick up most of the problems that patients has. And it's our problem. It's our problem. Everybody is telling the patient, you have to have this, you have to have that. So therefore, primary care is not important, but primary care is everything.
Yeah, that's very important. I think it's like crazy to see how many diagnoses are missed or things like that when you could just have like a regular family physician, you know.
You must remember, specialists don't see follow-ups. They see a patient, give the diagnosis, the patient goes home. I'll tell you what happened last week, Friday. So, and then they don't realize, the patient, the specialist they don't realize. So I sent a patient with a huge lipoma, probably 20 by 15 centimeters lipoma on just underneath the left scapula, just there. But it was a problem because if she's sitting driving, this lipoma was in the way. And when I've done an ultrasound, and it had a huge artery supplying blood, so I knew I couldn't do it in my office. So I phoned the surgeon. Yes, they'll do it. Okay, they did her, and they did it Friday morning. Well, I saw her about a week ago. Okay, so they did it Friday morning, and Friday night about 8 o'clock, my patient phones me. She said, I'm out of hospital. I'm on my way back to the farm, but I'm bleeding like crazy. I'm like, really? I said, okay, you know what? You're going to have to pass my house. Stop. I'll have a look. So at 8 o'clock Friday night, she stops at my house and I have a look and she's bleeding. It is like pumping out of her. I'm like, what the hell? I opened up. I couldn't believe it. They forgot to stitch her up in theater. She wasn't stitched. No stitch. Nothing. Zero. I'm like, okay. Well, it's Friday night, 8 o'clock. We are 100 kilometers away from the city that she just came out. I said, okay, you know what? I'm quickly going to put in the stitches. I put in the stitches. So that's why I say primary care is very, very important. It's not all about, and the specialist wouldn't have noticed that. She wouldn't have seen that. If the patient didn't bleed, she would have gone home and was living with this open wound. I don't know, probably till I see her a week later. I don't know, you know. And she didn't know, she wouldn't know about it. So I found her. I said, Linda, I've sent you this patient. She rocked up my house bleeding like crazy, and she wasn't, no stitches. You operated on her. And she's like, gee, Adi, you know what happened? I had an emergency call. I was on call. So I stepped out of the theater and I turned around and I told the junior doctor just to mark Clark, finish her up. That's what's finish up. Okay. And she walked out. And this junior doctor didn't think, okay, I have to put stitches in. They just slap on the dressing and that's it. And put a plaster and send her home. You know, so Linda would not have known. Just to let you know why the primary care health doctor is very important because we see them, the comebacks, we see the follow-ups, and we have to make plans, right? I phoned Lynn to tell her that because I was just thinking what happened, but otherwise I wouldn't have. I just put it stitches, which I did, and all the way. But I was thinking, you know what, she probably would know. And then she explained to me what happened. So she's going to pull the junior doctor on his ear. Yeah.
Wow, that's insane. The next question is, do you have any advice being a female physician to advocate for yourself in certain difficult situations?
Can we explain difficult situations? Difficult situations might be having children and get your children through school, giving it enough attention to your children. That's a difficult situation. Difficult situation if you have a male patient, you know, kind of making sexual suggestions. That's a difficult one. Difficult is a female doctor attacking you verbally. That's a difficult one. You or a matron having a difference. And again, I fall back to my motto of living daily by example. So I've never ever in my life had any male problems. Never ever had a male doctor or male nurse or a specialist sexually harassed me. Never ever. And it's because I immediately, when I walk in, I'm not a bitch, I'm not angry, I'm soft-hearted, but I immediately allow them to know that for me, you have respect. Immediately, this is my boundary. And I think by doing it for so many years, we laugh, we make jokes, we get in theater, but there is a mutual respect the moment because, and the mutual respect is if you start using foul language, if you start drinking with the boys, if you are removing yourself from getting respect. So I don't use foul language, and I can, believe me, I can, but in front of my colleagues, I try not to use that, but I can say, listen, and we don't like drink parties with, so there's a definite area of respect around me. And I think it's just being by 25 years, 30 years doing that. I mean, it's daily living, daily example. Okay, so.
And then when, I guess, to elaborate, the person also said for the certain difficult situations, they meant more like with other doctors. So I think more so like if you're in a group setting and if there's like a male physician, they might like step on your toes or so. Like, how do you kind of like stand up?
Oh, that does happen. So yeah. This is my modus operandi. I usually like to know a little bit more about everybody around me without them knowing that I'm gathering a bit of knowledge. Okay, just where they live, how old they are, what they like, etc. The second thing I do is when I work in a relationship with other doctors in a practice, I'm trying to find their strong points. Okay, so what is making them strong? Is it the way they diagnose it? Is it the way they talk to patients? Is it the way they approach a specialist? Is it the way they do surgery? Is it the way they put stitches in? Something small that I find. And then usually I will zoom onto that. Like, okay, this you're doing this very well. Can you show me? I like to see how you do this. Would you, you're doing an intra-articular injection. Can you show me your approach? Something I've been doing many years, but show me your approach. So I zoom into that and I make that a big story because that's how we are going to get this connected. How I'm going to get you my friend and you're going to stay my friend, right? And then if you have a problem, then let's say it's the way you talk to the nurses, or it's the way you talk to your patients, or I usually attend to that. And then at the stage, I will say, look, you know what, you're such a good surgeon, you're doing really good work, but the way you talk to a nurse, do you think we can make it? Do you think you can make it better? Do you think I can ask you, it's not what you say to her, but perhaps how you say it to her. And but I won't not do that when I see the person immediately, right? There has to be a little bit of a relationship. So that you can see, and then I will say, look, these are your strong points. You're doing really well. But can you think, I'm asking you nicely, to these little couple of things that's bothering you, you're going to be a great doctor. Most of the guys, most of the girls is happy with that. I had one that was very difficult, but the rest is actually in my lifespan. I never had a big fall out with any doctor, except one. There was one, but it was but anyways, the rest of the people I, come along with or communicate with, we usually have a very good, long-lasting relationship.
Right. Yeah. I think building the rapport is very important to not making them like defensive right off the bat, right?
And also in front of personnel or patients, you do that on the side. Yeah.
Another question is, when you were at your lowest low, how did you keep showing up for yourself?
Oh, that lowest low was last year when I had back surgery. Megan can explain. I had back surgery and I had all the complications in the world. So they had to take me back to theater and we had another back surgery. And actually, it's 1 year now. This next week, the 10th of March, it will be 1 year. It was the lowest low of my life. I'm a go-getter. I'm up, I'm going, and suddenly I couldn't get up. I had so much pain because of the complications and I didn't care. I didn't care about my patients or my staff. But at that stage, right? But one thing that I realized then, and this is in hindsight, is it is okay at the stage to say, look, now I'm not a good doctor because I am on morphine, I am on Lyrica, I am on Triptyline. I can't remember. Now I'm not a good doctor. You guys have to use what is available. And it was sad at that stage that I had a locum in place, but patients didn't want to see her. I was paying her a daily rate and patients, they went somewhere else. We went 100 kilometers to Port Elizabeth where I didn't want to see her. It was terrible. But in a way, it was a wake-up call for me to say, okay, you know what? And this is 1 year later. Also realize that you can only do so much. It took me 30 years to realize in 1 year that, okay, you know what? Actually, I can actually only do so much. And so, yeah, that's what happened in this really low with me, which is a good outcome, because I now realize that I've been working in this community for 25 years because I was in Canada for 5. I've been working day in, night in, work weekend in, weekend out. And suddenly I'm like, I'm going to work 1 weekend a month. The other weekend, my nurse is going to work, and I'm going to take 1 weekend off. And let's see how that goes. So for the first time in my life, I'm going to be 1 weekend away, and let's see how that goes. So.
Well, you deserve it after all this that you've given back to your community, I guess in addition to that, what are some other suggestions in terms of like self-care that either you do or you've seen other doctors do that you could recommend?
Okay, so, and I'm talking about the last year that happened in my life is I am taking 2 afternoons in 1 full morning off. Then we do the hair thing, the nail thing, that thing, okay? And then I take another full day, a month off, so that I can do my grocery shoppings and whatever. But then usually I try to make that a long weekend now. That's long weekend. So I'm off the weekend. I'm taking Friday, Saturday, and Sunday off, back the Monday. So I think it's very important to have the self-care. I never had it. Honestly, I never had it. But this back operation, all the complication, everything that went with that was a big stop street in my life to say, okay, whoa, slow down. It is, and it's okay to do that, but you have to kind of think you have to admit to yourself it is okay to do that. It was a big problem because I'm so busy and I'm seeing all these things and I can do all these medical procedures for all these patients, but it's okay to say, whoa, you can only do so much a day. Realize that now. So
and then another question is, what moment did you know the journey was all worth it?
Oh, I'm going to start crying. So my neighbor lady had serious problems with fertility, couldn't have a baby. So I was working one night in casualties. I wasn't supposed to be there. Casualties in Port Elizabeth phoned me, said, we have a big, huge problem. I just came back from Canada at that stage. It was 2010. And we definitely, honestly, can you just help us out one night? One night. And I'm like, okay, I'm just back from Canada. I'm quite tired, but my community doesn't know I'm back yet. So I think I can do tonight. So I'll come tonight. Anyways, I worked that night. And in the early morning hours, a young lady showed up at the emerge. She was about 30 years of age, and she didn't have any money, so she wasn't able to actually come to that hospital because they were charging money. Well, it's a private hospital, it's not the state hospital. So she comes to the door and she tells the receptionist that she's full in labor, and she cannot go to the state hospital. She refused to go. And the receptionist comes to the nurse, and the nurse said, oh, you know, this is an emergency. We obviously don't do any obstetrics here. I mean, she needs to go. And I'm like, whoa. Let me just quickly have a look here. And I examined the lady, and the head was actually showing. And I'm like, she's not going to make it there. Even if you calls want to send her, she's not going to make it there. It's 4 o'clock in the morning. And I put her down on the bed. I said, listen to me. You have to explain, you have to understand, I have no insurance to do this because this is an emergency unit. It's not. And she said, no, she understands that. I said, we're going to deliver the baby. And at 7 o'clock, so it's 4 o'clock in the morning, at 7 o'clock, I'm off shift. Nobody's going to take responsibility for you and the baby. I then have to send you home. Is that okay? Yeah, it's fine. I said, okay. The next thing, I'm like getting rid of my little stuff. I mean, I'm from the rural area. I can deliver a baby with 2 arterial clamps and a stitch cutter. I can do that, right? So I'm just kind of looking what I've got around of me. And the next thing, the matron of the hospital is standing in front of me, the night matron, like, doctor, what are you doing? I'm like, we're delivering a baby. She said, no, you're not. I said, yes, we are. She said, no, you're not. I said, okay, so what do you suggest we do with this lady? And we have a head pushing down. What are you suggesting? Well, we'll phone the ambulance. They can take her over to the state hospital. I'm like, not. Eventually, the unit of the emergency room, the manager came up. She's a nurse. She said, okay, whoa, I said, we are having a bit of a quarrel here. She said, okay, here's the story. We asked Dr. Schoeman to come and work here for the night. I said, exactly. So I don't care. You can fire me tomorrow morning. I'm not part of this hospital. I said, the matron doesn't understand my heart, but this girl I'm not sending away. And then remember, she's never seen an OBG. She went through the whole pregnancy without seeing an OBG. The emergency unit manager kind of pulled me away. She said, you know, she probably didn't have good OBG care. We don't know. I said, I don't care. She said, okay. If you're going to be the OBG then now, I will be the pediatrician. I said, that's right. Stand next to me. Let's deliver the baby, which we then did. Afterwards, everything went well. Well, she then turned around and she gave me the baby. She said to me, I cannot take care of this. I don't have the finances. I have 3 other at home. It's your baby. And then my friend that didn't have any children she was able to adopt the baby. And the baby is she's now 13 years of age. And 27th of March, 2010, she was born. So she's going to be 13 now, end of the month. And she's still in my community, and she is beautiful. And she's been taken care of very well. That was worth it.
Wow, that's an amazing story. Thank you so much for sharing that. I think if I don't have any more questions on my side, if anyone else has anything to add or any questions.
I just want to ask if any of these students wanted to come and shadow you in South Africa, would you be willing to take them in?
I would be willing anytime. It's a far ride with an airplane, but I'm willing to take them in anytime. And you know, you've been with me. You know, we can make arrangements. And actually, I'm close to the ocean, so they can have a week of holiday and a week with me or whatever. That's fine.
Yeah, no, you were truly super motivating and inspiring. And I actually messaged Megan on the side. I was like, I need to come to South Africa.
Well, anyone who wants to come, guys, I'm willing. You can shadow me.
Oh no. I think her reception tapped out.
Okay, we have load shedding. I'll
Oh.
teach you about shedding. So my generator is going to probably just kicked in, but yeah, we've got load shedding now.
Load shedding is just we have electricity issues in South Africa, and every couple of hours they shut off your power to save electricity for the rest of the areas. So that's what's happening.
Fine, the generator will kick in and we'll be fine. But I mean, yeah. So
Interesting. Yeah, I think that's it for us. If you have any last words you want to share.
thank you for inviting me. It's always nice to talk to new students, young students, inspire them. This is not, if you are doing this for the money of it, don't. The money will follow you, but don't go and dig for the money. Be a good, passionate doctor, live by example, and things will automatically happen for you. Automatically.
They're great words to live by. So yeah, thank you so much. And we really
Thanks.
appreciate you talking to us today.
Thank
No
you so
problem.
much. Betsy.
Thank you
so much.
for the invite, and I hope your class was enjoying it. Thank you so much.
Thank
We'll see you.
Thanks,
I said,
Ed.
yeah. Bye.
Bye.
Bye.